And we'll get started. Thank you all for joining us today for our April Neonatal GaPQC webinar. Our topic today is Breaking the Breastfeeding Iceberg, Changing the Culture and Building Your Team. I'm Kimberly Ross. I'm the Neonatal Quality Improvement Senior Manager at the Department of Public Health in our Office of Women's Health. And I help guide the work that we do here and support all the incredible work that you all are doing and that our leadership team is leading. We have a couple of updates for you. On April 13th, there's going to be a special screening to honor Black Maternal Health Week. It's Thane's Journey to Motherhood. You can register to attend at mamasvoices.org. The address is there. We can also put that in the chat. But that was a great opportunity for that screening. On April 21st and the 22nd, there's a symposium on the status of Georgia's girls. You can register by sending an email to that address there. We'll also put that in the chat in just a little bit. And you can let them know if you're interested in a virtual or there's an in-person option, and there's no cost to attend the symposium. And then on May 12th is the NICU Imprint Conference through Emory, the impact of social determinants of health on the NICU. And if you can, there's a little bit of echo, so if you can mute, that would be helpful. We are able to do, GaPQC is able to do some sponsored registrations for enrolled hospital teams. So if you have sent back your enrollment form or someone from your team has sent back your enrollment form for Optimizing Nutrition, you should have received an email from me with the codes to register that will make your registration free for that conference, either for in-person or for the virtual option. If you've returned your forms or someone on your team has returned your forms and you have not gotten that email from me, please email me, kimberly.ross@dph.ga.gov. Or if you are, you just haven't gotten your form back, you have it filled out, ready to go, or you're ready to fill it out and send it back, get that back in. There are some sponsored registrations still available. So I'll send you that registration code once you have your enrollment form back to me. And if you have questions, just reach out to me and I can look to see if there's an enrollment form for your team on file and make sure that you have that access or that code for the conference. So we're gonna just do a little bit, a touch on the Optimizing Nutrition for Georgia Newborns kind of overview. If there's folks who are joining us for the first time, we're really excited about our new initiative. We are ramping up for our June launch, which is getting very close. So we are laying some really great groundwork right now. We are looking at this initiative as quality improvement really at its core. And by doing so, we are doing minimal data collection. We don't want this to be a project on improving around collecting tons of data. We want to actually be able to see improvements in the metrics that we're measuring. So there's minimal data collection. This can be focused either in a NICU or in mother-baby. You can have teams looking at both at the same hospital. We have many hospitals that have returned enrollment forms for a NICU team and mother-baby team, which is really exciting. But we also have hospitals that are focusing in one area, which is also really great. And also teams are able to join, or individuals can join only to learn. And we'll go into the different tiers that you can join in just a second. Right now. So there are these two levels of involvement. The active improvement team, there's 3 requirements there, and then the learning collaborative, there's no real requirements around that in order to join for the learning collaborative. For active improvement, those requirements are identifying your project champion. You can see some examples of who those could be here. And within each group, we need a primary hospital contact for the initiative and a physician champion as well. And we also want teams to be able to demonstrate hospital support. So a senior leader, like a unit director, manager, hospital administrator who supports the project. And also, we will need a commitment to tracking and data submission. And again, that's limited data. It's monthly. We think it would take less than an hour. It's conducting an audit on 10 babies, either in your NICU or in mother baby, or in both if teams are doing both of those. With that active improvement comes the option to, or the opportunity to be named a GaPQC Center of Excellence in Optimizing Nutrition for Georgia Newborns. We'll be able to recognize teams who have high rates of microlesson completion and webinar attendance. These teams will also submit data regularly and on time. And this recognition is going to include announcement at the annual GaPQC meeting, listing on the DPH website and the GaPQC website, a template for a press release announcing the hospital status as a GaPQC Center of Excellence. So that can be something that's sent to local media to share the news of your achievement, a banner to be able to display at the hospital announcing that achievement, as well as graphics that can be used on your hospital's website, social media, in email signatures, LinkedIn, those sorts of things to show that you and your hospital is a GaPQC Center of Excellence and that the team members were a part of that work. So this is a level that can only be achieved for active improvement teams because there is that data piece that is a part of it. If you enroll as an active improvement team, you'll be able to work towards this status and this achievement. The second tier is that learning requirement or learning collaborative. And again, there's no like strict requirements around the learning collaborative. We ask that you have the opportunity to join our monthly webinars and you'll have access to the micro lessons that tie into the monthly webinars. Opportunity to attend the annual conference, just learning alongside the collaborative. There's no data submission for the learning collaborative, and then no QI coaching. And this can be a hospital team where a team gets together and says, you know what, we can't do data submission at this time. We want to join together and learn together as a hospital team for learning collaborative. Or you could be an individual who's just saying, I'm interested in this. This is something I really want to do. Maybe I can champion it in the future. Right now, I just want to learn, and you can enroll. You use the same enrollment form for either tier, and we'll walk through the enrollment form at the end in case there's any questions about how to get through those different tiers. And now we're going to move into what you're all here for today. And I want to introduce our speakers. We have 3 excellent speakers and very busy speakers, so some might be on and off of our talk today. And we just really appreciate them giving their time to be here. First is Dr. Taryn Fairley. She practices general pediatrics and breastfeeding medicine at Kaiser Permanente. She's a member of the Academy of Breastfeeding Medicine and adjunct faculty at the Emory University School of Medicine. She currently serves as the physician chair of the breastfeeding committee at the Georgia Chapter American Academy of Pediatrics and is the chapter breastfeeding coordinator. We also have Dr. Betsy Collins. She has a full-time clinical practice in OBGYN at Emory University Hospital, Midtown. Her clinical interests are preventative medicine, healthy living through life changes, family planning, and reproductive justice and advocacy, decreasing maternal morbidity and mortality, breastfeeding, and postpartum care. Claire Eden is at IBCLC and directs the breastfeeding initiatives at the Georgia chapter of AAP, including the EPIC Breastfeeding Education Program, and currently leads the Georgia Breastfeeding Coalition. So I will pull my slides down so that you guys can share yours. 1 second.
Oh, you know what? Sorry, it's trying to share through Teams, so let me try this again. Whoops. Okay. Let me play a slideshow. Here we go. Can y'all see that?
That looks great.
Okay, thanks everyone. Thanks for being here. I know that a lot of you are here live and some of you are going to be watching this recorded webinar. But those of you who are here live, I hope that you'll be able to contribute to the conversation. You know, this is a perinatal quality collaborative. So we're going to talk a little bit today about collaborating. Dr. Betsy Collins is here with me, and Dr. Taryn Fairley is going to be in and out. She got called into an emergency meeting, so we're going to be carrying on I wanted to kind of share this because I thought it went along with our topic today. The World Alliance for Breastfeeding Advocacy is who chooses the theme for World Breastfeeding Week every year. And I was really happy to see the theme for 2022 announced as Step Up for Breastfeeding, Educate, and Support. So maybe that'll give you all some ideas right now about how to be incorporating the theme along with your work with the Perinatal Quality Collaborative on optimizing nutrition for Georgia's newborns. So more about that coming up. But today, Dr. Collins and Dr. Fairley and I wanted to talk a little bit about doing some pre-initiative work since we're still in recruitment phase, and I know a lot of you are deciding about how to engage with this initiative and are building your teams. And when you kind of see people talk about education and quality improvement, you think about kind of the nuts and bolts, but we want you to think a little bit today about the culture change that could happen or may need to happen in your unit or in your facility, in your hospital, in your institutional culture. You know, we think a lot about protocols or maybe thinking ahead to like feeding plans and things, but really it's also important to think about the shifts in individual attitudes and behaviors that need to happen. So as you're kind of picturing your team and how you might put your team together or who's going to collaborate in your hospital, we wanted to talk a little bit about staff resistance and some of the topics that might come up around you know, people's feelings and thoughts about doing maybe yet another breastfeeding initiative if you've already had some in your institution, or maybe think about some of the reasons why you haven't already done a breastfeeding initiative if you haven't, or why it might have been set aside during COVID. So especially right now with a lot of staffing issues, it can be kind of the resistance from your team might be a challenge, and there may be folks that aren't actively resistant but are just kind of weary feeling or be having burnout. And those of you who are here, of course, are the ones that are excited and are hopefully not being forced to be here, but are here because this looked interesting to you and maybe looked like a support for some of the goals that you and your institution have already considered. But it can be exhausting to be the one person, the one kind of change agent every time. And to make your initiative sustainable, you need to be engaging the group so that you're not kind of risking burning out. So, you know, relying on those who are just not opposed to the initiative or are usually on board isn't really the best strategy. We need to kind of look at the bigger picture and get everybody aligned, or at least get a wide variety of folks aligned. So I'm hoping that we can scroll back to the beginning of today's chat. I posted some links to some poll everywhere questions to kind of help us feel out in the group that's here today, whether or not you have found, or in the past, whether or not you found breastfeeding initiatives to be controversial or polarizing in your unit. So let me try to get to where I can see the teams a little bit more. And maybe I can scroll back and post these again.
Okay, I can repost it later, Clara.
Could you? Yeah.
Yeah.
So the first question is just, have you found breastfeeding initiatives to be controversial? And let me go and share the right window here so we can look at our responses.
And as you go through poll everywhere, if it's asking you for your screen name, you can skip it if you want to answer anonymously today, or you can just make up a name.
Yes, thanks, Kimberly. I don't think I'm sharing the right screen. Can you see the results?
I don't see a screen.
Okay, hold on. Share content. Okay, here we go. How's that? Are you seeing it now? Okay, great. So we're getting some results in. There's a few people that aren't sure. Maybe this is you're new to the scene or haven't really noticed if there have been breastfeeding initiatives in your facility, but it looks like so far the majority are saying that they have found the initiatives to be controversial. So Kimberly, if you could post the second link is a question about getting some feedback on maybe why you think it has been a polarizing topic for QI in your institution. And I'll give you a minute to answer that one, and then we'll move to the next. Okay, bad experiences is one of the answers. We're going to touch on that. Burnout. Maybe a word cloud is not the best choice. We're getting some interesting responses. Emotional experiences. I see where I can put the words together. Maybe a one-word answer would be best. But I'm getting the idea that this is like maybe the first time initiative for some hospital. Some people feel forced. These are interesting words that I'm seeing. Staff burnout, having bad personal breastfeeding experiences. That's been my experience as well. And Betsy, while we're looking for some responses, I know this is one of the things you and I had talked about. In terms of people, when you talk about promoting breastfeeding, some of the responses that you've heard from your colleagues or from staff at your institution.
Yeah, I think very much this sense of like people feeling forced to do something that is a culture change is very hard. I don't know if anyone on this call has ever heard the term breastfeeding Nazi, which is a deeply offensive thing to say, especially, you know, in light of how we're all recognizing how words can hurt. But I think the term is incredibly reflective of how people feel about breastfeeding policy in the clinical setting and how they view it as an imposition instead of a quality initiative that may be promoting policies and culture changes that are best for our patients and healthiest for our patients. So a lot of what Claire and I had talked about yesterday when we were thinking about this meeting was talking about the professionalism of nutrition and breastfeeding and understanding that quality initiatives are not something that you do. It's not a flavor of the month. It's not, you know, it's not because we like the color blue best. We do it because it's evidence-based and it's science. So in the same way that we have antibiotic policies about how we use them around surgery, for example, or, you know, stroke protocols, how we feed our patients is another important component of their health. And it's really important to recognize that quality initiatives are based in medical science and evidence, and then are intended to produce a high quality, high fidelity result. So professionalizing nutrition and breastfeeding medicine is incredibly important because we need to get stakeholders. And if we don't professionalize this and don't talk about the science, people view it as an imposition or just something else to do.
Exactly. And I think we saw some of that in those responses. So when we're looking at how change can happen, I think there's some important, let me get to the right slide. It's important to consider that it's hard to separate our own experiences, especially, you know, when you consider how visceral early parenting and breastfeeding can be for a lot of folks. And that can really color their kind of their approach. And really, the other thing we really want to acknowledge as we're getting started with this initiative is that the vast majority of health professionals have received very little formal education on human lactation, on the physiology of lactation, on factors that can affect lactation. There's just, from a medical standpoint, there's really a big lack of fundament. And then there's also been some really interesting recent studies around physicians specifically and how conflicted they can feel about not having met their own goals for breastfeeding, especially those that had poor support themselves, as a lot of physicians are having babies like during residency, for example, and how hard it is during the as a trainee to have good support for breastfeeding. And there's some culture change happening, and the AAP and the CDC, I know specifically, are trying to address this with ideas around making a breastfeeding supportive culture for medical trainees specifically. But that's been shown in the literature to show that affects how physicians feel about supporting their own patients with breastfeeding. And then, of course, nurses have the challenge of, when staffing ratios are rough, breaks that are important for lactation and maintaining lactation may not happen, or are happening late, or are shorter than they need to be for nurses to be able to meet their lactation goals. And that can be a really big challenge in terms of feeling enthusiastic about supporting patients. And then that sort of post-traumatic stress from that can affect perinatal mood and also affect kind of assumptions that we make as part of the team about who may or may not be successful around breastfeeding. So one thing that we wanted to suggest that you all consider is holding some listening sessions with your staff and with stakeholders. And that can happen a variety of ways. It could happen in a huddle, it could happen in a staff meeting, or even informally, having some listening opportunities to hear and help recognize what some of the folks in your team or your unit have experienced themselves that may affect the success of you undertaking this initiative. Another way to do that would be to do a survey that could be more anonymous. And we're going to pull together some resources on how to do some surveys that assess knowledge, attitudes, and behaviors on your staff, so you can kind of start off with an idea of where things stand. And then, Betsy, maybe you could talk a little bit about the idea of identifying champions, because we want to address, kind of balance champions with also involving folks who may be the more resistant among your team.
Yeah, I think that's really important to pick, or to pick is probably not even the right word, but cultivate champions that are exemplary in terms of quality and standards of care, and also people that are really able to verbalize and communicate why a quality improvement project is needed. Because I think so much of this, getting back to talking about science and promoting lactation and nutrition in this setting, is about being able to articulate how important it is for our patients. And if you don't have champions that truly understand quality and also the science behind this, they won't be able to make the case for some of these quality improvement projects. So you really want to look for people that are leaders in their field, but also across different groups, because we need people not only in mother baby, on labor and delivery, anesthesiology, NICU, nursing, lactation. You really have to get, it doesn't even have to be that many people, like one or two people from across these spectra, because then you have to be able to take that group and approach your hospital quality leadership and say, hey, this is really important. This is the evidence. Look, we have this coalition. we really want to institute this program. We could be recognized. This will be really imperative when we're doing our J-code reporting, or when we are seeking baby-friendly status, or our GaPQC certificate. So you really have to have the broad base. You have to have people that are motivated, articulate, focused on science, and feel strongly about working together, and willing to take those next steps.
Right, thank you. I really liked the idea about moving infant nutrition out of the realm of the anecdote. So I should have had this slide up while you were talking, but recognizing that this is personal, deeply personal for many of us, but also from the standpoint of patient care, we should be using an evidence-based and professionalized viewpoint or way of working. Considering that breastfeeding success can look a lot of ways for different families, and that we really should be centering what the family's goals are for breastfeeding, and then make sure that we're kind of assessing what environmental and systemic supports or lack thereof are there. And remember that, the social determinants of health breastfeeding can really magnify the social determinants of health. So
can I say one thing, Claire?
Yeah, of course.
So one of the things that we had talked about as well yesterday that I really think is important to say is that a lot of people think that because they breastfed or had a bad experience with breastfeeding, that makes them experts at breastfeeding. And a lot of the conflict we've had in women's health in general has been between this idea of routine experience, like having a baby is a routine experience, but being a parent does not make you an obstetrician. Having fed a child at your chest does not make you a lactation expert. And so it's really important for us to recognize why evidence-based medicine and quality are so important in this realm, because number one, that's going to guide us in terms of making changes that benefit our practices and our patients. But number two, it's going to help us convince people that they don't know it all, and that they still need to be active adult learners in this space, because we do get a lot of pushback. Oh, well, I breastfed a child. That makes me an expert. I don't understand why I have to take this class. I've worked as an obstetrician for 30 years. Why do I have to take a lactation class? And the answer is because just because you eat vegetables doesn't mean you're a dietitian. Just because you've breastfed a baby doesn't make you a lactation expert. Just because you've been pregnant doesn't make you an obstetrician. Professionalism is super important. And in order to make our practices better, we have to make evidence-based decisions, not anecdotal decisions. Oh, well, I know a lady who once did this, is not science. And we need to really make sure that we're making science-based recommendations. And the only way to do that is to have professional quality improvement projects.
Agree. Thank you. So one way we're going to kind of use this analogy today to look at this around, this has been used a lot in business, or maybe you've seen it in other applications, but this idea that what we see is the top of the iceberg, and that's sort of like the way that we say that we get things done. And those are those obvious things like policies or written down strategies or the vision, the mission statement for your organization. You can think of some of the taglines. I've worked at CHOA for a lot of years, so I have those in my head that, we're dedicated to all better, or these sort of obvious things that we see that are written, and this is how we think that we're accomplishing our goals. But really, the things that are underneath or invisible are really maybe the way that things actually happen and get done. And those are those sort of shared assumptions or unwritten rules, perceptions that folks have, traditions in your unit, norms and mores, kind of people's individual stories. Are all contributing to really kind of what's happening. And we can use those things to, if we acknowledge that, then we can use those things to help us make some progress. So we're going to break some things down from top-down change, which is the kind of the way we think things happen, and also look at the bottom-up change and how we can harness that and use it to help make quality improvement. So some of the ways that you can kind of break up that iceberg, or think of the whole picture, is starting with lining up some top-down change to kind of provide context to your QI and to get things moving, right? By like communicating to everyone that the leadership is involved. And that's why it's important for this initiative to line up some administrative support. Back almost 10 years ago now, when the CDC started funding some hospitals in Georgia to become a baby friendly and to do some of those maternity care improvements, the funding was dependent on there being administrative leadership involved in each of those hospitals. And, many of you who've been around for a long time know that sometimes an individual or very small group will say, we're going to do some breastfeeding improvement here, or we're going to apply to be baby friendly, but without and this initiative is not about becoming baby friendly, but it's similar in that we are looking at maternity care practices that affect breastfeeding success. So lining up some administrative support is really critical. And, of course, those of you who are here, you are part of that, obvious, we are engaging here at X hospital, we're going to do this initiative, and you're the public face of that here. But part of that lining up your team is getting some administrative leadership. Another step to look at is identifying change agents across the organization. And that's looking at people maybe who aren't necessarily in leadership, but that everyone knows are the people who get things done in your unit. I'm sure many of you can think of how that works right now, but who are maybe the informal leaders, thought leaders, people who get things done, people that are looked up to in your unit and respected, and identify who they are, so the change can happen not only at the top down or organization level in a policy, or for example, but who's training the most preceptors, who affects people's opinions about how well something is working in your unit. And the first step is identifying them. The second step is getting those people involved in some work groups to work out specific issues. So this is all kind of corporate speak. So in a healthcare setting, it would be getting a work group together, not just a breastfeeding task force, but maybe a work group about a very specific thing, is everyone in your unit know how to help a mother with hand expression? Or is there a way to move information in your EMR from prenatal assessments to get them in front of nursing that are taking care of a nursing dyad of mother baby? So once you've identified some really specific tasks, you can get some of those change agents involved to really become a catalyst to encourage change that is bottom up as well as top down. Once that's happened, even if it's just a little thing, you can publicize those grassroots efforts and successes. Spin is important. You can turn a lot of things into a success, even if it's not as maybe as wild a success as you were hoping for. Even saying 10 nurses were trained on how to set up a breast pump this month, or whatever, or all of our new staff or all of our travel nurses receive this education. Any small little thing you can do to publicize those catalysts and change agents that you identified and what specific changes they made can really help build a kind of an impetus or some momentum around your initiative. And there's lots of ways to publicize that, right? It could be in your in a huddle, it could be in your staff meeting PowerPoint, it could be in the hospital newsletter, it could be on the break room bulletin board. I know some hospitals have little, ways of recognizing colleagues that you can enter online and people can earn points. You can even just brag to their supervisor about their work, and really publicize even those really small changes can really help build some momentum. I really like this idea around building on some early wins. Betsy is going to share some of that as we move on, but I think finding those early wins can really help affect people's perception of the initiative, and that, the standard doesn't have to be that every baby is exclusively breastfed, right? Like that's not going to be realistic. So we're going to build on small wins and early wins early in the initiative to kind of color people's opinion about how things are moving along, getting more people involved and empowered. And then, of course, kind of rinse and repeat there. Yeah, finding opportunities to build on those wins and repeat, and to encourage the movement of change in your unit. So in the third question, I'm sorry, was that you? Really? We're going to ask for folks to identify what kind of resistance you might think you'll encounter. So that can help us promote and design the initiative to make it easier for you all to experience success. But we'll put the link for the third question in the poll everywhere in the chat. And then I'll go get out of this and I'll go show the responses that you all are sharing about what kind of resistance you think you might encounter with this initiative in your unit. So let me go over here. Whoops. Hold on. Okay. Oh, interesting. So I'm hoping, Kimberly, if you can unmute and give me the thumbs up, or Betsy, that you all can, that I'm showing the right screen. Are you guys able to see the responses people are giving?
Mm-hmm. It's coming as a list, so we can't see them at the same time. Yeah.
So I'll scroll back. So people not being invested in the outcome, the expense, I thought that's interesting. Old school, yeah, right, like moving people on, keeping them up to date, the time it's going to take, people being passive aggressive, burned out staff. Wow, I love that somebody pointed out prenatal education, because that's such, as we've been designing this, it's really, we've realized how big of an important piece prenatal education. And then of course, getting pediatricians on board is really critical. Taking too much time. I'd be interested to know, and if somebody wants to put in the chat, do you think it's the documentation that takes too much time? Is it the education that takes too much time? Here's another time concern. We definitely face apathy in this area. Inconsistent education. That's definitely something that we're going to have plenty of educational opportunities and a way for you all to get everybody on the same page. Let's see. Forgetfulness. Would love to hear more about that if anyone wants to put in the chat. I like this idea. I don't like it, but I think it's important that somebody mentioned, and this is something I alluded to before about, we don't want to only just have a number, increase. The QI needs to be sort of set in this setting of actually improving the quality of care that we're providing. Lack of time. Okay, these are really interesting. Thank you all for contributing there. Let me get back to our PowerPoint. Okay. So when we're breaking up an iceberg, the old ice, the most like entrenched the ice from 2,000 years ago or whatever is going to be the hardest to break. So in order to drive engagement in the initiative, it's going to be important, like I mentioned before, to address emotions people have, their stories, their own stories and past experiences, and their the only way to do that really is to elicit it. It's to acknowledge and validate people's experiences, and help us move from this idea that breastfeeding is, successful because somebody tried really hard. I mean, of course, trying hard, it doesn't hurt, but a lot of people being able to meet their breastfeeding goals is dependent on factors that they don't have control over, and acknowledging that and validating people's experience can be a really important part of that. And that can also help you kind of realign on what the shared goals are, and getting input from the whole unit about what your shared goals should be is going to be important. Kind of another critical angle on that is acknowledging that our fundament as healthcare providers may not be perfect. Like, we may have education we need to do. There may be practice improvements we need to make. We may need to update our own, potentially better practices as well. And that needs to come from the champions as well as, the kind of the more those who are just participating in the project. This is a line from Betsy, so I'm going to kind of let her address this change, but I really liked the idea when Dr. Collins and I were talking about this phrase about you can't really have quality without fidelity. Do you want to expound on that, Dr. Collins?
Yeah, so once you've identified that you need to make a quality improvement, have to do it with high fidelity, right? Because essentially what you're saying is, this change is required to produce this outcome that is a highly desired outcome. And I like to talk about some of the other things that hospitals have done to improve the quality of the services that they provide. And one of the things that we did at Midtown was that we really focused on surgical site prophylaxis with antibiotics. And we noticed that a lot of doctors were just ordering whatever. Like, they would order a medicine that they used when they were a resident 20 years ago, or they would, order doxycycline because it was Tuesday. And so what we did is we took antibiotic ordering away from, 500 surgeons and made it the responsibility of 100 anesthesiologists, and then said, these are the procedures that get antibiotics. These are the antibiotics that the patients will receive. And on our surgical site checklist, we will identify, that the patient required antibiotics and that the correct one was used preoperatively. So obviously we needed buy-in from, surgeons, from anesthesiologists, OR staff, the whole thing. But everyone understood that the reason why we needed to do it was the prevention of surgical site infections. And then we, on these multiple levels with high fidelity, made sure that the chance that you're going to get off of that path into a low quality or medical mistake result is limited, right? You want to make sure that you are getting the same high quality result every time. And that's why it's just really important when you're thinking about a quality improvement project, if it means starting small and knowing that, hey, every month I know that Susan and I can review those 10 patients in the NICU, and I know that we can collect that data and it'll be high quality data, then pick that project because you know that you can carry it out. But you don't want to pick something where you don't have buy-in and you're not going to get those early wins. Because if you fail at something because you don't have the institutional support, Claire pointed out that there's several hospitals that are backing away from baby friendly. And probably my guess is the reason why they're doing that is, number one, they're not meeting their metrics. And number two, they don't really have deep rooted grassroots support. They had a couple champions that encouraged that process to start, but then they didn't have they didn't have the buy-in from other people across those service lines, and they weren't able to produce a high fidelity change. And so it's really important that you pick these small wins so that you can build that coalition. And so if you do make a big policy change, you can keep it up.
Yeah, and I liked this idea about, you know, when we talk about why we're doing a quality improvement initiative, we also, it can be helpful to look at why it's needed, you know, what are those system level failures that we're trying to address, and maybe why we haven't done this yet. You know, why is the time right now? Part of the reason for that can be thinking why we haven't done this before, what's been holding us back. So we thought, you know, we just kind of jump in with real talk today, a little bit about, you know, Dr. Collins just mentioned there are some hospitals in Georgia that have been, were previously baby friendly designated and are dropping their designation. And, you know, breastfeeding and the 10 steps have been and are, you know, somewhat controversial. So I think it's important to really look at and acknowledge that the 10 steps are evidence-based. And studies do show that the 10 steps show improvement in breastfeeding and infant mortality. You know, the more steps are implemented, the better. There's actually a really good recent study that I can get in the chat here at the end, especially in, that was done specifically with low-income families. But it's also important to acknowledge that not all of the 10 steps have the same level of evidence, and that interpretation really can vary, and that can be complicated. And so Dr. Fairley, I think that you're here with us. I'll let you maybe kind of jump in here.
Yeah, talking about real talk today. This whole, the graphic, the inset photo here on the right shows some clips from Fed is Best, which if you haven't heard of it, it'll probably come up in some of your pre-work for this initiative. It's certainly out there for public consumption, is something that families certainly read, health professionals certainly access and read, and it's kind of, I guess, if we have two poles in this whole discussion, Claire, it's probably the other end is the other pole, kind of away from baby friendly, is this Fed is Best controversy. And I have many layers of thoughts and feelings about Fed is Best. Also, can I just say that I loathe the term as a pediatrician? Like, I think we can do better than just feeding people. I think Fed is basic, Fed is first step, right? That's the only real rule I have for parents is please feed the baby. But at the same time, unfortunately, they make some points that I think are important for all of us to kind of understand. We can take the next slide now. And it's true that, you know, while baby friendly is a compendium of evidence from the World Health Organization and UNICEF, and there is an evidence base for it, it's not perfect and the evidence level varies greatly. So the best evidence amongst the 10 steps are for rooming in and for early initiation / skin to skin care. And so those do have good efficacy. Those do have good evidence for improving initiation and in some studies duration of breastfeeding. But there's also, you know, unexpected events that occur with, you know, with supine positioning that with an infant. And so there's some near SIDS incidents and some SIDS-like incidents that have occurred during skin to skin care. And while the numbers are low, it's 100% for this, you know, for the staff that are involved. It's not a low incidence for them. And it very much has emotional ramifications, even for contacts, other health professional contacts.
Uh-oh. Dr. Fairley froze for me.
Can I, while we're waiting for Dr. Fairley to unfreeze, can I make a comment too that I think is really important to the Fed is Best conversation?
Yeah.
And that is, don't let perfect be the enemy of the good, right? This is like one of the most important things to think about. If you're a patient with heart disease, starts eating a lot of vegetables and has one burger, you don't throw your hands up in the air and say, I can't believe you ate that one burger, even though you've been eating vegetables for the last 2 days. You know, it's all over. Like, you know, this is terrible. You just say, okay, like, let's eat lots of vegetables. It's okay to have a burger here and there. Like, you have to be flexible. And I think this idea of like all or nothing is a real Achilles heel. And we need to move away from this idea that, like, you know, any formula is terrible, or like our patients are going to get some formula sometimes. How do we do it in a way that helps support breastfeeding and infant nutrition and doesn't undermine the patient's goals, right? Like, center the patient, not your, you know, extreme views about, you know, 100% this or 100% that. Like, that's not real life. And we just need to be okay with that.
Yeah, I agree. Dr. Fairley is going to try to jump back in, but hopefully you all can see the slide. Again, she was talking about which of the steps have kind of the best evidence. One of the steps that has maybe the least evidence is around avoiding pacifiers or teats, bottle, nipples. And the new guidelines and evaluation criteria from Baby Friendly USA have addressed that to some degree. And I think it's really interesting that she called out here which of the steps sort of have the poorest interpretation, and that is around supplementation and what rooming in looks like, and that it means you can't ever have a nursery, or that you have to, you know, get consent for medically indicated supplementation that's like written, or these sort of like long drawn out consents around formula supplementation. It's really just about documenting and counseling, and, you know, you can have safety measures in place to make sure that medically indicated supplementation is being caught, right? That it's medically indicated, and not relying on individual assessments for that. Let me see if I can get to the next slide. There's been some recent, and I know I'm running a little short on time, so there's been some recent discussion around perinatal mood disorders. There was a paper published in the this month's Journal of Perinatology from some obstetricians that had. This is a really good example of how people's individual experiences, which they kind of outline in the paper, affected their thoughts and feelings around breastfeeding, and they have some concerns about not centering parental needs when promoting exclusive breastfeeding, which are probably valid and really kind of draw a line to this inclusive approach that is needed. And I just wanted to kind of call out that IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education, their website is lacted.org. They're offering a day-long perinatal mood disorder workshop in June. It's really inexpensive. It's only like $75, I think, if you're not a member of IABLE. And I'll promote Dr. Collins is one of the speakers. So I hope that if this is an area that is of interest to you all, that you join. Dr. Collins, you want to promote your talk?
Yeah, please join us. It'll be very exciting. I've done a lot of work with Peace for Moms, and I'm certainly very invested in health in the peripartum period. So I think it'll be really great. And then, yeah, I think, it'll be fun. Join us.
Yeah, and the objective of the workshop is to just help people gain confidence in how to address and screen parents for perinatal mood and anxiety disorders, but also really put an understanding of how lactation care recommendations need to accommodate mental health needs. And, you know, especially in the setting of, 2 years into a pandemic, that has probably contributed to a lot of mood disorders in general, but also in the perinatal setting. So to kind of wrap up, we thought, and I know Betsy, you've addressed some of this, but if you could talk a little bit about your experience at Emory University Hospital Midtown and as a case study. and apply some of this talked about?
So one of the things that happened to me was my wife had a baby, and I was graduating from residency and thought I knew it all, and then hit postpartum and felt like, a lot of people were like, oh, did you feel like you learned a lot when you were pregnant? And I was like, I learned the most when my wife had a baby, because I knew nothing about postpartum and had very little training in really what it means to provide high quality postpartum care. And so my wife had a lot of breastfeeding difficulties with our first baby. And I think the lactation consultants saw an easy mark, and they were like, they were like, would you like to help us with our baby friendly journey? And I was like, oh yeah, this sounds like a great idea. And so I ended up becoming a champion because we had a really rough experience. And then at the time, there was sort of another big groundswell from the lactation consultants to move towards baby friendly status. And there was a really great program that we engaged in that was a 2-year program through CDC that helped support some of these easy wins in order to get on the baby friendly journey. And then when we did the program and we're building our broad coalition, at the end of that 2 years, we felt ready to go ahead and apply for baby friendly status. And we did really have to engage a broad coalition, but it worked great. And even one of the steps, like buying infant formula, which was really difficult, we got the finance people on board and worked closely with our purchaser, and she was fantastic. So it just goes to show you that things that might seem really hard, if you build a good coalition and you're working sort of in the middle of that iceberg, the people at the very top and the small group of people at the very bottom will join in and will support the cause. But what you really need is that group through the middle, the doers, the nurses, the finance person, the purchaser, the quality improvement officer, all of those people played a role. We professionalized the service line, and then we were able to implement those major QI projects to get our baby friendly designation, because we had all of these different groups on board. So it really paid off in the end. And I think the other thing that really motivates me in this process is equity. And when I was reading that article that you sent, Claire, I think one of the things that really stood out to me was having the choice to choose breastfeeding or choose not to breastfeed, and being able to have a voice in your care experience is a privilege. And reading that article felt like a lot of whining from people with a lot of privilege. And so I just want to say that this is about access, right? And making sure that the most vulnerable people of color, people who are uninsured, people who are undocumented, people who have high rates of morbidity and mortality receive the same quality care as anyone else. And that's why I got into this work, and that's why we should be doing this work. And focusing on the complaints of people who have access and privilege is not where I'm at in this space.
Yeah, thank you for that. For those of you who are able to come to the Emory Breastfeeding Conference, Dr. Zakiba Henderson presented, and I heard her speak maybe 5 years ago, and really stuck in my head that you can't have quality care without equitable care, which reminds me of you saying, like, you can't have quality without fidelity. Thank you for bringing that in. Whoops. Okay, so Dr. Fairley, are you able to jump in to help us wrap up?
Yes, hopefully with what proves to be a more reliable connection. My apologies. So thoughts on change from those of us who've been doing this for God. Claire, do you want to quantify how many years you've been working in lactation? I think mine's close to 20 now. I don't know what that says about me. I started as an infant.
Yeah, we're getting close to 50 years between the two of us.
Yes. So with a half a century of battles under both of both of our belts, we can tell you that with this initiative, probably even compared to most work, you want to hold listening sessions. You want to get the vibe of your team and get a sense for the underlying issues early on, because that old ice is hard to break up and will flummox any type of top-down change you want to do later. It's best to ferret it out and go from there. And you know, we have to acknowledge that there are issues with some of our underlying evidence base, and we do no service to ourselves as evidence-based clinicians if we don't acknowledge that the research out there for hospital-based maternity breastfeeding practices, right, isn't perfect. We have to acknowledge that. And we have to acknowledge that there's some trauma for staff who've been working in the field for the babies that they see coming back with, you know, very high belly levels, who've lost a ton of weight that they had just discharged a few days before, right? Like, we have to acknowledge that there's trauma, that exclusivity isn't for everyone, and that safety and patient goals are first. And that is kind of the way to align staff. And I'm sure Claire and Betsy spoke much more eloquently to this earlier in the talk, that the one thing I think even the naysayers can agree upon is that we're there to support a dyad's goals safely. And then my personal take on most of these types of interventions is that those who are the most concerned and resistant get to be the most involved in intervention. And this not only goes with my vaguely misanthropic tendency to punish people with meetings, just kidding, not really. But also, like, you want to use that animus, right? That energy, that negativity, and turn it around. It's an enormously powerful thing. That energy is there. We might as well transform it.
Thank you. We'll pass it back to you, Kimberly.
Thank you so much. Thank you, Dr. Collins, Dr. Fairley, Claire. This is excellent presentation. I hope everyone took away lots of great items to build your team. What we don't want is for anybody to feel like you can't participate because you can't build a team or you're missing a key person on a team. We're here to help move past those obstacles. So reach out if you feel like there's few things in your way to be able to get a team together. We want to be able to support building those teams. I do want to show, this is the enrollment form. I think all of you have seen this by now and should have it. If you do not have it, you can email me. I will send it to you. My email is there at the bottom of it. It's also about to be in the chat. And send that back. What I'm going to be doing soon is, of the enrollment forms I have, I will be emailing the project champions a document so that you can give me the contact information for all of your team members. So the enrollment form just has space for like your champions for the most part. We want everybody on your team who you want to have access to the webinars and the micro lessons. So there'll be the spots there for you to put that contact information. Those folks will be added to our Microsoft team so that they have access to the recordings of webinars, to the invitations for the webinars, all of that. And then also access to the Train platform, which is where our micro lessons are going to live. So we need contact information of everybody. So if you have 15 nurses that you want to have to be able to access these trainings, I'll need that. If there's 30 that you want, that's fine. Anybody can do these trainings that have access. We just want there not to be that barrier of not being able to sign into Teams or that sort of thing. So that will be coming. Be on the lookout for that. We appreciate your time today. As always, reach out with anything that we can do to support. We are here for you to make this initiative successful and ultimately to support those mother-baby dyads across the state. So thank you all. Have a wonderful afternoon, and we will see you in May.